Let's begin with our emergency medicine lecture, and our today's topic is constipation management. First, the scope of the problem, and this is the Rome criteria, and the different landmarks which are included in this Rome criteria. First, which is the fewer than 3 bowel movements per week. So if there is less than 3 bowel movements per week, and then the hard stools, and there is excessive straining to remove those hard stools, and then sense of incomplete evacuation. So all these 3 characteristics are important as far as Rome criteria is concerned. So if there is less than 3 bowel movements per week, if there is hard stool and there is excessive straining present, and then sense of incomplete evacuation after the process of defecation, this all is in the Rome criteria. Then let's talk about some anatomic essentials as far as the constipation is concerned. First, we should know the normal bowel function. So unless we know the normal bowel function, we cannot differentiate it from the abnormal bowel functions or abnormal bowel activity. So first, let's go over what's the normal bowel function and how it leads to the process of defecation. The first is the colonic transit. The gastrointestinal tract we have the small intestine and then the large intestine. The large intestine is the colon, and we have 4 parts of the colon. We have ascending colon, transverse colon, descending colon, and then we have sigmoid colon. The transit of the fecal matter through the colon, what helps this is the structure you can see of the colon. We have ascending colon, then the transverse colon, descending colon, and then this is the sigmoid colon. So colonic transit, movement of the fecal matter or the waste matter through the colon. What helps it? It is kept up by smooth muscle function. So smooth muscles of the colon, it helps in the movement through the large intestine or through the lumen of the colon. So kept up by the smooth muscle function. Contraction of the smooth muscle, which is known as peristalsis. Peristaltic waves are responsible for pushing the food forward, and because one wave comes and it pushes the food. When there is no peristalsis, no movement of the bowel after some abdominal surgeries or ileus and different conditions, then this can cause lack of movement through the colon. So it is kept up by the smooth muscle of the colon. Then another mostly overall control of this colonic transit is by the peripheral nervous system. We have central nervous system, which contains the brain and the spinal cord, and then we have peripheral nervous system, and this is controlled by the peripheral nervous system, the colonic transit. So the overall control is by the peripheral nervous system. Any abnormality in that also leads to abnormal bowel function. So that's the colonic transit. The other part is the actual defecation. Defecation is in the normal defecation is relaxed sphincters, pelvic floor muscles. If the sphincter is relaxed, then we have the process of defecation. If the sphincters are closed, sphincters are the opening between the cavities. And these sphincters allow the substance or material from one organ to another. If the sphincter is not relaxed or open, then there is no defecation. So relaxed sphincters, relaxed anal sphincter, we have internal and external. It leads to the process of defecation. Coordinated with increased intra-abdominal pressure and entirely are reflex act. Reflex act occur as a result of stimulus which is present. So it is the stimulus is the presence of the stools or the fecal matter that initiate the reflex act, and it cause the act of defecation. So these are the two main parts responsible for the normal bowel function: colonic transit and then the defecation. Colonic transit is by the smooth muscle and by the peripheral nervous system function, and then the defecation is by the relaxed sphincters and pelvic floor, coordinated with increased pressure in the abdomen that pushes it down, and then it is a reflex arc or reflex act that occurs to the reflex arc. Next, the abnormal bowel function. So after this, we should know what's the difference between normal and abnormal bowel function to further, so we should know further that what's the constipation and what's the normal bowel movement. So abnormal bowel function, we have a normal transit constipation with difficulty evacuating. So transit is normal, but there is difficulty in evacuating the fecal matter. So the transit time is normal. It means the smooth muscle part is normal, the peripheral nervous system is normal, but there is problem in evacuation. So there is problem in this relaxation of the sphincter or the muscles. There is problem in the reflex act mechanism, which can be due to any injuries, spinal injuries, and the injuries at different level. So all these are they can lead to the abnormal bowel function, which is difficulty with evacuating. Then the other problem can be slow transit constipation with infrequent bowel movements. If the transit is slow, then the bowel movements will be less and it's infrequent. And we already know that in the Rome sign or Rome syndrome, we know that it is the less than 3 bowel movements per week. So it's infrequent bowel movements. Then pelvic floor dysfunction, failure to relax, strain, partial evacuation. So all these are the abnormal bowel function. The complications associated with abnormal bowel functions, the complications are rectal prolapse. As a result of the straining to expel the hard stool or hard feces which is present in the constipation, this straining leads to rectal prolapse, and prolapse is the bulging of the structure out. So when the person tried to defecate, there is wall of the rectum that bulges out and there is prolapse as a result of the weakening of the muscle due to the straining. So rectal prolapse is common with constipation, and you can see that's the rectum wall that or muscles that comes out during the defecation. Then another is anal fissure. Again, it's common and it's a painful condition. Again, as a result of straining, there is fissure or excoriation present in the anal region, and it is very painful, and it even causes blood in the feces. Hemorrhoids again as a result of straining. Chronic cough can cause hemorrhoids also. These are the dilated rectal blood vessels. There can be internal hemorrhoids or external hemorrhoids, and they need to be treated. Otherwise, patients sometimes have really bad attacks of the blood loss or bleeding through these dilated blood vessels, which are the hemorrhoids. Fecal impaction, incomplete evacuation. There is fecal impaction as a complication. Then fecal ulceration. You can see ulcers develop in the perianal region or as a result of the even inside the rectum in the wall because of the straining, and there is bleeding from these ulcers, and there is also pain. And then spurious diarrhea. It's a condition in which, because of the hard stools, which cause the blockage of the lumen, there is leakage around the hard stools, and this causes the spurious diarrhea, and it's the watery flow around from the hard feces. So all these are the complications. Prolapse is common, anal fissures, ulcerations, hemorrhoids, spurious diarrhea, and again the mechanism behind all these different factors is the straining and the pressure exerted cause the hemorrhoid, cause the prolapse, and leads to different complications. Next, the red flags, history, and the concerning diagnosis. Again, red flags are the warning signs which tells us at what point we should consider that the condition needs the further follow-up. So red flags, we have the severe abdominal pain. Severe abdominal pain is common in bowel obstruction. Diverticulitis. Diverticula are small outpouchings that are formed in the wall of the intestine, and the entry of food particle into those pouches sometimes cause inflammation, and it can cause abdominal pain, and colon cancer can also cause severe abdominal pain. Bowel obstruction. In the surgical department, you see a lot of patient who comes with the bowel obstruction, and they have abdominal swelling, and they have all that guarding and rigidity, and when you do the x-ray, you see the obstruction, and there is rupture of the bowel also with the air under the diaphragm, which is very, very characteristic of perforation. So all these are important. So severe abdominal pain. Next is the fatigue and lack of energy. That's the other red flag, another warning sign. As a result of blood loss from the fissures, from the hemorrhoids, the patient might feel very weak and tired, and there is sometimes blood which is not visible to the naked eye. So we need to perform different tests if there is blood in the stools or not that cause the anemia, and there is fatigue as a result of anemia. So anemia from gastrointestinal blood loss, hypothyroidism. So these are again two conditions which cause fatigue and lack of energy. Another is the weight loss, unintentional weight loss, again, colon cancer, other malignancies, and diabetes. So, all these are the warning signs: abdominal pain, and especially lack of energy, fatigue is maybe the due to blood loss that leads to anemia. Then another important points, there is vomiting, abdomen distension. It is due to bowel obstruction. So bowel obstruction patients usually they have vomiting and they have abdominal distension as a result of obstruction. Then change in the stool caliber, again, that's important. Colon cancer or anal fissure. Then the alternating diarrhea and constipation, these are the patients who have a history of alternating diarrhea and constipation. So sometimes they have diarrhea, sometimes they have constipation, and these are very common patients which have irritable bowel syndrome, IBS, and inflammatory bowel syndrome, Crohn's disease, ulcerative colitis. It's very common in those patients and also patients who have the colon cancer. Then history of medications. Some medications also leads to the constipation. So history of medication is also important. And drug side effect, it can be as a result of the side effect associated with some particular drug. And then tenesmus. Tenesmus is the partial defecation, that feeling that is associated with the partial defecation, that sense of irritation and a feel of going to the restroom and having and the bowel movement, we can say, but still it's hard to pass the feces. So that's the feeling that is known as the tenesmus, and again it is due to anal fissure or perianal abscess. Abscess and fissure is associated with tenesmus. Next, sweating, headache, and flushing. This is due to autonomic dysreflexia diagnosis. If there is sweating, headache, flushing, it is due to autonomic dysreflexia diagnosis. We already mentioned that the normal bowel function is associated with peripheral nervous system, which is the autonomic nervous system also. So autonomic dysreflexia is presents with the sweating, headache, and flushing. Newborn irregular stool pattern. In the newborn irregular stool pattern, we have Hirschsprung's disease, meconium ileus, and imperforate anus. So newborn with the abnormality in the defecating process, very common Hirschsprung's disease. It's the disease in which the ganglion cells are missing, and it causes the abnormality in the passing of or in defecation. Then meconium ileus, thick meconium cause obstruction, and it causes meconium ileus, and then imperforate anus. If there is no perforation, no opening, definitely there is no defecation, and all these we can very easily diagnose them on the abdominal x-ray. So this is very common in the newborn babies. Rectal foreign body insertion. If there is any foreign body, that can also lead to obstruction and cause constipation. And then fecal incontinence, diarrhea. If there is no control on the fecal output or outflow, and if there is diarrhea, this is usually due to fecal impaction with overflow diarrhea, spurious diarrhea. Due to overflow diarrhea, when there is obstruction because of hard stool, there is overflow around the hard stool, and this causes the overflow diarrhea. Next, acute onset constipation. What are the conditions which leads to acute onset of constipation? Colon cancer. Colon cancer can cause acute onset constipation. Bowel obstruction also cause acute onset constipation. Drug side effects. Inflammatory bowel disease, diabetes, diverticulitis, hypercalcemia. Increased calcium level also cause acute constipation. It affects the functioning of the smooth muscles and it causes constipation. So all these are different conditions that cause acute onset of constipation, which is less than 3 bowel movements per week, straining, incomplete evacuation. So all these are causes of acute onset constipation. Then the examination findings and concern diagnosis, the abnormal vital signs, some conditions which are associated with the abnormal vital signs, and in the vital signs we have the temperature, pulse, respiration, and the blood pressure. Most of these conditions are associated with the low blood pressures. There are abnormal vital signs. So we can see like bowel obstruction. Bowel obstruction is very common and it can cause decrease in the blood pressure. There might be tachycardia and tachypnea present. So bowel obstruction. Then we have ischemic bowel. Ischemic bowel is due to, again, mainly due to poor blood supply, cause decreased supply of oxygen, and it causes ischemic bowel. The other is Ogilvy syndrome. This is again the dilatation of the colon. You can see Ogilvy syndrome in which there is dilatation of the colon. Then we have peritonitis, inflammation of the peritoneum. In bowel perforation, we usually get the peritonitis when the infection reaches to the peritoneum covering of the abdominal organs, causing peritonitis, and there is very bad tenderness and guarding and rigidity on abdominal palpation. Another is the stercoral ulceration. You can see the ulcers form in the lining. So these are the stercoral ulceration. Next, the important conditions again, cachexia. Cachexia is the weakening and weakness, unexplained weight loss, weakness. Cachexia is the characteristics of malignancy most of the times. Then blood on digital rectal exam. On the digital rectal exam, if you have blood on the gloves, that's again due to colon cancer, diverticulitis, or inflammatory bowel disease. Abnormal neurologic signs, which is due to any neurologic abnormality. Again, the abnormality associated with the nervous system, especially the peripheral nervous system, can lead to the constipation. Then anal stenosis, if there is narrowing. Stenosis is the narrowing, and if there is pouch, blind pouch, both these can cause constipation. And the cause is the imperforate anus in the newborn. So all these are different conditions, and on the findings we find these: there is cachexia, weight loss, if there is blood on the digital rectal exam, any neurological signs, stenosis, and a blind pouch. All these are the concern diagnosis on examination finding. Now, some other examination finding and concern diagnosis is focal tenderness and guarding is very common in the abdomen. When we palpate the abdomen, there is tenderness on palpation and guarding. Patient try to contract that area to avoid the pain. That's the guarding. So there is focal tenderness and guarding, very characteristic of perforation. So intestinal perforation, as I mentioned, is very common case when we are working in the surgery. You see lot of patient who comes with perforation. Maybe perforation of the ulcers is very common, and that leads to the perforation, and we see these cases all the time, and there is tenderness, guarding, and rigidity. Ischemic bowel, and then diverticulitis. Abdominal distension and borygmy sounds. These are the loud sounds as a result of the gases in the abdomen or in the intestine. So this is again characteristic of bowel obstruction. Confusion, hyperreflexia, and hypotonia. When reflexes are increased and the tone is decreased, these are characteristics of hypercalcemia, increased level of calcium. Then there is confusion, hyporeflexia, and hypotonia. Hyperparathyroidism and malignancy. Parathyroid is the gland which is responsible for the calcium level, and hyperparathyroidism can cause increased calcium level also. So these are the conditions which are associated with confusion, hyporeflexia, and hypotonia. Now, the questions we need to ask the patient in the history: bowel movement frequency, important, less than 3 bowel movements, hard stools, difficulty in defecation, all they are important in the history. So, bowel movement frequency, how often, last bowel movement, and if there is any pain associated with it. Consistency of the stool is again important. Problem with constipation. Then some associated symptoms with the constipation: fatigue. We know the fatigue is due to the anemia, which is due to the blood loss. If there is constipation, there is anal fissure, there is ulceration, there is hemorrhoids. All these can cause blood loss, and patient will have fatigue and weakness. Weight loss, unintentional weight loss, abdominal pain, and fecal incontinence. These are all the associated symptoms. Some other associated symptoms are the diarrhea. And this diarrhea, in case of constipation, we already mentioned, is the spurious diarrhea, which is water that is present around the hard stool. When it comes out, that present as a diarrhea or watery diarrhea. So there is diarrhea. Then vomiting is common, especially if there is obstruction and perforation. It can lead to vomiting also. Hematochezia, fresh blood in the stool is hematochezia. That's the difference between melena and hematochezia. Hematochezia is the blood coming from the lower colon. Melena is dark brownish blood that comes from the upper GI. So hematochezia, and then there is tenesmus, incomplete evacuation sensation. So all these are some associated symptoms with the constipation. Past medical is important. Any medications which are prescribed, or if some patient use some over-the-counter medications, make sure you should know all the medications that the person is using, which can cause constipation. Dietary habits is very, very important. Lot of people who don't eat fresh fruits and vegetables, they are mainly the people who eat the meat, that they are more prone to develop constipation. So plenty of fluid, fresh fruits and vegetable with lot of fiber is very important to prevent the constipation. So patients who have the constipation, always tell them that they should have plenty of fluids and they should eat fruits like watermelons, and then fibers. They should eat the vegetables, and they should eat less red meat. So dietary habits is very, very important. Additional lifestyle factors. People who don't move around a lot, they sit for a long period of time, they are more prone to develop constipation. So these are some important questions to ask in the past medical history. Physical examination. Physical examination of the patient, vital signs are important to take. Uncomplicated constipation, signs of sepsis. Uncomplicated constipation usually doesn't affect the vital signs, but in case if there is sepsis, there is low blood pressure, there is that can cause shock also. There is tachycardia, fast respiration, fast heartbeat. All these are present. So vital signs. Then in the abdomen, mild distension, tympani, stool may be palpated. If the stools are hard and they are not evacuated, you can feel those hard stools. And then there is tympani. There is a sound which is the resonant sound as a result of presence of the gas or air that is also present. Then the rectal exam, which is digital rectal exam, anus inspection, fissure, obstruction. It's important to examine the anal region to look for any fissures that might lead to pain and the bleeding during the defecation, and also for any obstruction that is present. Digital rectal exam, we already mentioned, is very important. If there is blood on the digital rectal exam, it is maybe due to the colon cancer, diverticulitis. Head to toe physical examination, hypothyroidism, decreased thyroid level, very, very important cause of constipation. Thyroid is the hormone which is responsible for metabolism. If there is no metabolism, there is no digestion of the food we eat, and it causes constipation, it causes excessive weight gain, it causes sluggishness, it causes drowsiness. So hypothyroidism is an important factor. Conditions like diabetes, again, is important cause of constipation. Look for any lymphadenopathy, any enlargement of the lymph nodes, which can be due to any malignancy which cause the enlargement of the regional lymph nodes. Anemia, less count of red blood cell, decreased hemoglobin level. So all these are again cause of constipation. Some neurologic causes, we have Parkinson's disease, where we have fine tremors, cogwheel rigidity, shuffling gait. Very characteristic of Parkinson's disease. There are fine tremors of the hand, cogwheel rigidity. If you try to bend the hand, there is there is cogwheel rigidity. Clasp knife rigidity is also known as, and there is shuffling gait. Paraplegia, paralysis of all the upper four limbs, upper and lower limbs, due to previous ischemia, trauma, tumor, surgery, or it may be congenital. Acute spinal pathology. All these can cause constipation, because if you remember in the previous slide, we talked about that it's a reflex act. And this reflex act or reflex arc is affected in the spinal injury, in the paraplegias. So it can cause a constipation. So acute spinal pathology, abnormal tone, motor reflexes in lower limbs. Demyelination. Myelin is the covering of the nerves, and when that is demyelinated or there is destruction of the myelin sheath, it can also cause constipation. There is focal neurologic deficit, spinal peripheral nerve distribution. Some other autonomic dysfunction causes, we have lability of blood pressure, labile blood pressure. Labile, what's the labile blood pressure? Lability of blood pressure. When there is a rapid fluctuation of the blood pressure, it becomes high or less. So that's the lability of blood pressure, if with sudden changes in the blood pressure. Lability of heart rate, again, tachycardia, bradycardia, it keeps on fluctuating. Urinary retention, orthostatic hypotension, sudden fall of blood pressure on standing. These are again due to autonomic dysfunction. Next, let's go over some causes or the differential diagnosis of the cause. And first, let's go over some most common cause differential diagnosis. Range of medications. Different medications cause the constipation, and there are different range of medications. Then lifestyle factors is again very common cause of the differential diagnosis that can cause constipation. Immobility leads to constipation. Inadequate intake of fiber and fluid in the diet. Pregnancy and abuse of the laxative. Painful perianal region, and especially if there is hemorrhoids, you can see the hemorrhoids are the dilated anal vessels that cause the bleeding. There is painful perianal region. Psychogenic, depression and anxiety, both very common psychiatric disorder, they can cause constipation. Irritable bowel syndrome. Some less common causes or less common differential diagnosis, we have the neurogenic disorder like multiple sclerosis and cerebral palsy. metabolic, which is diabetes and hypothyroidism, diverticulitis and inflammatory bowel disease like Crohn's disease, volvulus hernia and adhesions. Adhesions is one common cause of bowel obstruction, and these adhesions are formed maybe due to previous surgeries or inflammation. There are adhesions formed that attaches the intestines to one another, and it causes obstruction or the paralytic ileus. Then volvulus hernia, again common cause. Intrinsic bowel lesions like ischemia or the tumor. Some uncommon and rare causes, we have hyperparathyroidism, uncommon and rare causes. Scleroderma. Scleroderma is the condition, it's the disorder of the connective tissue that causes tightening of the skin, and it's the rare cause of constipation. Lead, arsenic poisoning also can cause constipation. Amyloidosis, in which there is amyloid protein deposition, and it is another cause of the constipation. Then the differential diagnosis of the cause in the pediatric age group. What are some common conditions? Intussusception. Intussusception is one part of the intestine enters into the another part, and it causes blockage. So intussusception. Coercive toilet training and diet. Meconium ileus, rectal atresia, when there is blockage due to the meconium and there is atresia of the rectum, all these conditions can cause constipation. Cystic fibrosis, it can cause constipation. And Hirschsprung's disease, in which there is absence of ganglion cell in the intestine, it also causes constipation. So all these are the common conditions in the pediatric age group. Imperforate anus, that's another condition when there is inability to defecate, and then you look for there is no perforation of the anus. Surgery is performed to create the opening. Diagnostic testing. We have lab studies. In the lab studies, complete blood count is important to look for hemoglobin level, anemia. Electrolyte levels is important. Renal function test, liver function test, and thyroid function test. All these are the important lab tests. Some radiologic studies, very important if we need to diagnose any perforation, obstruction, it is helpful. When secondary cause like any rupture, perforation, obstruction, intussusception, volvulus, and the erect supine radiographs. Outpatient studies, colonoscopy, examination of the colon, very commonly performed to look for any cancers or growth or cause of the bleeding. Anorectal manometry, study of the muscle activity in the anus and the rectum. Balloon expulsion test. Defecography, recording of the process of the defecation, and sigmoidoscopy. All these are the tests, outpatient tests that can be performed. Treatment principles in mild cases, senna and docusate, 2 tablets per oral 4 times a day for 3 to 4 days. psyllium metamucil up to 30 gram per oral daily in 2 to 3 divided doses. Milk of magnesia. So all these are the treatment options for the mild cases. 30 to 60 ml regular strength liquid. For moderate cases, lactulose 10 to 20 gram tablet, lactulose 15 to 30 ml syrup, glycerin 1 suppository per rectum, magnesium citrate 150 to 300 ml per oral, and sodium phosphate, fleet enema. Severe cases, soap, suds, enemas, or enemas with warm water, glycerol, and magnesium citrate. Some special patients, elderly, decreased fluid intake, develop complications. Neurologic disease, usually they have recurrent issues. Fecal impaction, antihypertensives. Pediatric non-specific organic causes. And various diagnostic risks are present. Disposition, how we dispose these patients, review of history, physical exam is important for disposition. Then the inpatient evaluation may be required. Outpatient referral to gastroenterologist is sometimes recommended. Home therapy, excluding serious condition. Unless there is serious condition like perforation, obstruction that needs emergency treatment or rather emergency surgical treatment, the most of the time the home therapy is enough for the constipation. Some pearls, pitfalls, and myths. Thorough evaluation of patient. Alarm features, rectal bleeding and pain. That's alarming feature that needs to be diagnosed and followed. Feces on radiograph, normal. Constipation, a symptom, not a diagnosis, and related to diet, medicine, lifestyle. Another, abdominal pain should not be attributed to constipation. Abnormal vital signs never considered due to fecal loading. Constipation may be an adverse outcome of emergency department visit, and dehydration, renal impairment, serious side effects. So that concluded our topic of management of constipation. Thanks for watching sqadia.com.